Hello, everyone, and thank you for joining us today. My name is Natalie Boyum, and I am the president and founder of the Defeating Epilepsy Foundation. We are a 501c3 in Southern California, and our mission is to provide the educational and advocacy services needed to the epilepsy community and our society. Today, our guest is Dr. Daniel Neuberger. Dr. Neuberger is the Assistant Medical Director of the Huntsville Hospital Emergency Department. He is board certified in emergency medicine and has been practicing for 6 years post-residency. Thank you, Dr. Neuberger, for joining me today.
Thank you for having me.
Thank you. Many people with epilepsy have had numerous trips to the emergency room due to having prolonged seizures or going into status epilepticus. Doctors and nurses in the emergency room are working in a high-stress environment. Many patients with epilepsy have had negative experiences in the emergency room for many different reasons. One of our goals at the Defeating Epilepsy Foundation is to help improve doctor-patient relations to prevent negative experiences for our patients and to help those in the medical profession understand what epilepsy is. Dr. Neuberger, can you explain to our supporters what you do and what the environment of an emergency room is like?
By all means, yeah. So the emergency department is obviously the front door to the hospital. It's where a majority of admissions come through, and patients present with all sorts of complaints. Anything from heart attacks and strokes to lacerations, seizures, and everything in between. And our job is essentially the first couple hours of care of any patient who presents to the hospital. So we really see it all, and every emergency department is different. So uh, it keeps it interesting for us.
Oh, most definitely. Now, I've noticed over the years, going to different hospitals and learning and meeting other professions. It could be focused on trauma. It could be more of a general background. There's times when having the need to work with certain specialists may be challenging. So it's a very good point to bring up to our supporters that it's not a one size fit all type of environment, depending what hospital it is.
That's very true. I mean, you have emergency departments that see well over 100,000 patients a year, and you have some that may see less than 5,000 a year. And obviously, the capabilities of the departments are going to be very different, and the training of those in those departments are different. I think I shared with you earlier that I primarily work at two hospitals, and they're very different. One's a almost 1,000-bed hospital, and one is a less than 100-bed hospital. And the specialty call lists at those hospitals are very different. And, we have similar resources in the emergency department, but from what we can handle in the hospital standpoint, it can be quite different.
Very good. So what are some of the common situations that patients are brought into the ER for?
Yeah, so we have people come in by private vehicle and by ambulance, right? And like I said, it ranges from people who are incredibly unstable, who need to, who we're actively resuscitating by doing things like CPR and breathing for them, putting them essentially on life support, to people who walk in who need, a couple of stitches. And in this past year, it's been a lot of respiratory symptoms as well. And, we're obviously used to dealing with that, but that's been a much larger share of our patient presentations here recently. So,
And COVID has played a very big impact on the medical community. And I think at times patients don't realize with the pandemic how overwhelming this can be for people in the medical profession.
it is, the other patients haven't stopped coming, is what I'd say. So, we're used to operating near our limits, and now we have a completely new disease, and the patients that go along with that. Fortunately, right now things are a lot better than they were a couple months ago, but and we hope it continues in that direction. But I think everybody in most hospital systems, we're were pretty incredibly stressed and at the limit in late December and January of this year, and I know our health system was.
Oh, absolutely. How common is it for a patient to be brought to the ER for a seizure?
I'd say it's pretty common. Uh, we see several a day. So it's not an uncommon occurrence whatsoever, and something that we're definitely used to dealing with. And I think you were talking about it in your introduction a little bit about people being brought for kind of seizures that weren't stopping in status epilepticus. And that's obviously kind of the severe presentation. But as you and your supporters certainly know, frequently if you have a seizure in a public place, paramedics may be called because people are concerned for your well-being, and so it ranges from people presenting saying, I had a seizure, it's not a big deal, I have these, this is normal for me, to people who really need intervention quite urgently. So
Oh, absolutely. Because that's one of the things we've talked about in our organization. We have a YouTube channel and we made a series called Understanding Epilepsy. And one of the things that I was very passionate about, and luckily my interns were the same, was when we were talking about different types of seizures. One thing I made clear was we have to tell them what the seizure first aid is for this certain seizure, because a lot of people know seizure first aid and they think of a tonic-clonic seizure. But like you said, somebody might have had one, and by the time paramedics get there, they're like, I'm fine, I don't need help. Or in situations, I've had complex partials for many years. I haven't lost consciousness in 16 years, but when I used to have them real bad, the best way I can describe it is I came off as under the influence of something. So if someone didn't know I had epilepsy, they may assume I'm drunk or high and having a bad reaction to it.
yeah, and I think that's an important part for I mean, even in the medical profession, among physicians and nurses, there's this, oh, I can tell by looking at somebody what a seizure is and what a seizure isn't. And that, I mean, as you know, that's borders on nonsense,
Yeah.
because people's seizures are very different. And yeah, and um, I think having a patient tell you why they're in the department is so useful. And sometimes seizure patients with epilepsy or experiencing seizures can't tell you that, which makes things difficult as well. But
Oh, absolutely. So when a patient is brought in for having a seizure, what are the important steps an ER team must take to stop the seizure?
yeah, so I think any patient presenting to the hospital in the ER is going to be stabilization initially, right? So we touched on it, but some patients in status are quite unstable. They're having issues with their airway, they're having ongoing seizure activity, maybe vomiting, maybe at risk for aspirating or taking some of that vomit into their lungs and having real breathing issues. But yeah, we always try to stop the seizure activity if we can. Frequently, our first line is going to, for acute seizures like that, are going to be benzodiazepines, and anti-epileptics on top of that if needed. It can escalate everywhere up to barbiturates and deep sedation for people in status. But frequently, small doses of benzodiazepines are enough to stop seizure activity if it's ongoing.
Yeah.
Frequently the seizure activity has passed by the time a patient makes it to me, but if it's ongoing or recurrent, that's kind of our first go-to.
And that's good to know that you're following a variety of options of what you feel is best at that point for the patient. And you brought up some really good things that when you have patients coming in who maybe the seizure has already stopped, but they're feeling the after effects of it, that's just as important to address. Myself, when I was younger, I had grand mal seizures and I always got very sick and vomited after because of the overactivity. And when I had one of my last ones in 2002, a doctor prescribed me something and I had an allergic reaction and I had a seizure without warning, which had never happened. I had always had an aura. And when I arrived at the ER, I was in a neck brace because I had crashed my car and they wanted to do an x-ray first. And I started getting extremely nauseous and I got so scared that I was going to get sick and choke to death. And I think the only reason I didn't was thankfully the nurse talked me through everything till they could get me down to x-ray and everything. So it's like, I think people don't realize how much doctors and nurses do in the ER to keep the patient stable and really help that momentary environment to make sure that things don't escalate.
Yeah, I think your point about nursing is well taken. Obviously, as physicians, we're talking with the patients and ordering medications and labs and all that, but the majority of the time in the room is spent by nurses and even techs, talking with patients and talking with families, and frequently they even get history that we don't, just because they're in the room more than we are, and they can definitely contribute to your care.
Absolutely. Do you feel doctors and nurses in the emergency room understand how to care for people battling epilepsy?
I guess I'd say overall, yes. We see it enough. Whether or not everybody practices the same or is providing ideal treatment. Obviously, everybody can improve, but yeah, I think most people, they try their best to care for these patients and provide them with the best outcomes that they can. Sometimes we need help from our neurology colleagues, especially in patients who are in status or otherwise unstable, or with medication adjustments. Frequently patients who have had an increase in their baseline seizure activity and I can't come up with a clear cause need medication adjustments. And if somebody's on multiple anti-epileptic drugs, that's something that's outside my area of expertise. So I find myself calling for help, essentially, and trying to get in contact with their neurologist to see if they have any recommendations that we can use.
And I think that's excellent to show that because I feel, at least in my personal experience being in the ER, that so many doctors or nurses are expected to, in a split second, come up with the answer and just make the move. And I like how you said the fact that that was pretty much out of what you normally do, and that you resorted to calling a neurologist when it came to a medical, medication change or something. And I think that's good for supporters to know that there's medical professionals who aren't just going, oh, I have the title, I know what to do, I'm just doing it. It's good to see that doctors know to act as team players and consult with one another in the best interest of patients.
Right. It's really important. And kind of going back to what I had said earlier, it's nice being at a bigger center sometimes when you have access to those consultants. Or if a patient can tell me this is my neurologist, I can frequently get in contact with them if I feel it's something that's necessary, if we need to be making medication adjustments. Because it doesn't do very much good to change your medication if that's not what your neurologist wants. Because then you're just going to get it changed again in a couple of days or weeks when you see your neurologist. So
Absolutely. When it comes to caregivers, what can they do when a loved one is brought into the ER for help? Anything, examples would be giving medical information, or if they follow a care plan, what can they do to make it easier for your team?
yeah, I think that's a great point. And as you know, frequently a patient who's just experienced a seizure can't give a great history to us, or it might take them a little bit in order for them to be able to give us a history. And so having a caregiver or a written care plan can be extremely helpful. It's something we struggled a lot with here over the past year due to limitations on visitation, not just with epileptic patients, but with everybody, is the person who witnessed the event or the person who knows your seizures can be just incredibly helpful and give us a more complete picture of what's been going on, or why you may have had a seizure this time, or why you were brought to the hospital. I find that a lot of times a good question. Well, a question that I like to ask epileptic patients presenting to the ER is why they came in this time with their seizure, because I find that frequently epileptic patients, well, most of the time, they don't come in right
Yeah.
with their seizures. They manage these at home, and it can range anywhere from this is an increase, this is a different type of seizure, it's a different experience I had, to I was just out and about and somebody called, and or I was at work and somebody called, and that's why I'm here. And you can get an idea of how concerning the presentation is, because it can be not concerning at all to the patient and just a kind of circumstance is why they ended up in the hospital, to a hey, I'm used to having one seizure every 4 to 5 months, and I've had 5 in the past 24 hours. And that's just very different.
Yes. No, it is. I mean, the time when I mainly was taken to the hospital, it was due to status. But once my my seizures were changing, and it turned over to complex and simple partials. It got to the point where I didn't go to the hospital. If I had one, I knew it would be over in a few minutes and just to rest, or if I would get auras. If I knew it was going to be a bad day, I knew just take my emergency meds. I was at that time, my emergency meds was 2 milligrams of Ativan, and I would take one every 12 hours. I knew the moment I had aura, take it and get back in bed, and 9 times out of 10 I could avoid having the seizure.
Right. Definitely. Definitely.
Yeah. So for patients who have had a negative experience in the ER, what would you suggest to them?
Yeah, I guess I'll put on my medical director hat, instead of my treating physician hat. But we listen to patient concerns and complaints, and it's a thing that changes policy and changes behavior, actually. So reaching out, not necessarily in an angry way, but to provide tips or comments on our care is definitely worthwhile. It definitely changes practice, and people might not realize that they're either brushing off a patient's complaint, or treating them with disrespect, or otherwise causing them to have a bad experience in the department. I think it's very few people's desire to provide care that is unsatisfactory to the patient. And sometimes it's a matter of pointing out why. Um, the other thing would be that, while you're having said experience, trying to express what's making it be that way or seem that way can be helpful.
Oh no, absolutely. And I mean myself, I've had a couple negative experiences, but I've had to learn to become stronger from them. I find the only thing I've done in the couple times I've had to go, I have to remind myself the bad experience I had, don't allow what that happened to overlap into the situation if I need help. I can think of one time not too long ago. I had COVID and they really didn't believe me at first in the ER. It was before it really hit hard in my area. And they came and they took blood twice, and by the third time I was exhausted. I had been there for almost 6 hours, and I told the phlebotomist I just needed to rest. And when the nurse came in, he was angry with me for turning the phlebotomist away. And I admit I got assertive with him about it. And I look back now and I felt really bad about it, but I decided to use it as a teaching experience because 3 of my interns who write for our blog are pre-med students. And I told them, no matter what area of medicine you eventually go into, I said, there's going to be a time you're going to come across a patient like me that's had a real horrible experience and something just might trigger it. I said, the hardest thing you're going to have to learn to do, and it's not going to be easy, is to be able to mentally take a brief step back and go, why is that happening if it's too extreme? How do you bring them down? Because if you get defensive and upset them even more, I go, you could be just adding on to the trauma. So I told them it's going to be really hard to find a balance when it comes to emotions.
Right. No, I agree. And there are all sorts of reasons to have bad experiences in a
Yeah.
hospital setting, and particularly in an emergency department. And it's something we struggle with a lot, is You touched on a little bit, but demand for care is higher than kind of our ability to provide it, which is unfortunate, right? So
Yeah.
emergency departments are frequently extremely full, right? And there are significant wait times. And it's one of those things that we try to make better always, but it's a reality of our health system. It's that it may take several hours to be seen in the department, which isn't our desire, but it's the unfortunate reality.
No, it is, and what I've noticed myself, my sons they don't have epilepsy, they have hemophilia. And for a while, my oldest was having ankle bleeds, and to the point where for a good month we had to have him in a wheelchair when we went around because he just couldn't put any pressure on his feet. And a couple times when I took him up to Children's Hospital in LA, most of the people there, you could tell the kids there were probably like a bad upper respiratory infection, some type of real viral bug where, it was limited to what they could do. But sadly, you could just sense because of the level of poverty, they didn't know what else to do at the moment. It was, my kid is sick. I gotta get some level of help. And I don't even know where the nearest urgent care was besides the Children's Hospital emergency department. So you could just see patients who come in, it's not always an absolute emergency. It's so many parents who just don't know what to do, but know they have to do something.
I would agree with that. Obviously, the majority of our visits are kind of what I would deem emergent, but also we are the safety net for everything else, right?
Yeah.
When other places are closed, and for the uninsured, we find ourselves managing a lot of things that other people with more resources, or more education into their kind of disease process may see their doctor or the next day or the next couple days. But if you don't have the ability to do that, we're open.
Exactly. So I have had both positive and negative experiences when having to go to the emergency room due to epilepsy. What can patients do to help establish a positive experience between them and any doctor or nurses that care for them?
Yeah, I think kind of setting expectations is a really important goal, and something to discuss with the physicians and nurses. If your goal is to leave the department because you're not concerned about your seizure, then that's fine. In all honesty, I've had people who have checked in, they had a seizure, they were at work, they got brought in by ambulance, and they say, this is fine. I want to go home. I have a ride, and I'm not concerned about this. And the last thing I want to do is, keep that person in the department for 6 hours, right?
Yeah.
Running tests that they don't want done. And that frankly don't need to be done if it's usual for them. But on the other hand, you also don't want to send somebody home who's very concerned about what has happened to them prematurely. And you also don't want to set people up for failure in terms of having additional seizure activity, shortly after discharge. I mean, I think anybody who's been practicing emergency medicine long enough has seen an epileptic patient for seizures, and done a big workup, talked with them about going home, and they've seized in the wheelchair or while walking out of the department. It's one of those realities, and I mean, we hate it when that happens because the
Yeah.
patient's not happy and you feel like you didn't do a good job for them as well. So like I said, I think setting expectations, what your concerns are up front, and you know don't feel like you can't tell a physician or a nurse what you're concerned about. I mean, we're here essentially to listen to your concern and see what needs to be done about it, or what should be done about it.
And I think that's good that you brought that up because I find when it comes to doctor-patient relations, I feel there are a lot of wonderful doctors and nurses out there. I mean, like any profession, you
Mhm.
you have a couple, unfortunately, who are bad, and it tends to tarnish other people when they have a bad experience. They start labeling others in the profession, which is very unfair. And I was even guilty of that at one point of having a couple real bad experiences with neurologists. I'd be told, go see another one. And I'm thinking, oh, great, what am I going to have to deal with again? I had that negative, I won't lie, I had that negative outlook at it. But I think it's important that you do communicate. Or if you have, I have a couple friends whose seizures are not controlled. They have a basic care plan drawn out, and they have the families give it to the hospital so that if they go in again, it's in their file on record in the computer, so that the team there has an idea of what's been going on and what they need to do.
Right, definitely.
Okay. One time I was taken by ambulance to the emergency room for having a complex partial seizure. The team thought I was under the influence of drugs despite having a medic bracelet on. I feel medic alert bracelets can be life-saving and EMTs should look for them. For patients battling epilepsy, how important is it to have a medic alert bracelet?
I think it's really important. I think you brought up the episode where you had the car crash,
Yes.
right? And you were injured from a car crash. Uh, you know, and frequently the first people on scene may be police, okay, in those type of episodes. And I think that most first responders, including police officers, will frequently look for that immediately because is this person confused because of an injury from the wreck? Are they confused because of what caused the wreck? Or are they confused because, like you mentioned, could they be under the influence or something like that? And a bracelet like that can help them a lot. Not just in epilepsy, but we think of a lot about this in diabetic patients as well. It gives people a lot of information up front. Especially in the first responder type of field. And if you're not able to identify yourself when you come to the hospital, or if you've never been to a hospital before, what's nice now, and I guess ever since I've been a physician, is kind of the ease of access to medical records is great, right? So if we can identify you and you've been to the hospital before, I mean, I can frequently look up your last admissions, your last clinic visits, your last EEG, your last MRI, all within a couple of minutes. And that definitely didn't used to be the case. But imagine coming across a car wreck or somebody on a sidewalk or something like that as a first responder. All you have is what you see, and if you see a med alert bracelet like that, it can be make a huge difference.
Oh yeah, it can be life-saving. No, and I think the reason I really bring it up is, I'm hoping my experience was just once a bad one, but I feel that it's really important for not just even medical professionals, but people in general, when there's a situation that would arise like this, that people would have a seizure, to really check to see if something is there. And myself, for years, I didn't want to wear one because of my experience. When I had that experience, I literally threw mine in the trash, and my mother was furious. And I said, well, if they're not going to check for it, why would I put that on my
Why
arm
am I
and
wearing
be
it?
be stigmatized by it, having people look at me like, oh, what's that for? What's wrong? But what really made me change my attitude about it was when both my sons were diagnosed with hemophilia. I got little medic alert necklaces for them, so that if they had something happened at school and they had to call for help, the fire department, the ambulance, they would know what was going on. And I thought to myself, well, if I'm making my sons do this, I'm a pretty big hypocrite if I don't wear one too. So I finally admit I broke down and bought one, and I make an effort when I leave the house to always make sure I have it on my arm. And I admit it feels weird now, but I know I'm setting a positive example for my sons and also for other people in the community, because really the passion behind my work is to educate and advocate for people here in this community, but also to educate outside. And if I'm telling people, you got to focus on overall wellness and you need to take care of yourself and do this, and I'm not playing by the rules, who would take me seriously?
That's true. That's true.
So, is there anything else you would like to share with us today?
Not particularly. I think kind of just touch on what we talked about earlier,
Yes.
in that having an open line of communication with those providing care, in an emergency type department would be the best thing that can be done. And express your concerns. I mean, if you're being discharged from an ER and are concerned about something, ask about that concern, because it may not have been brought up, or it may have been told to, the registration person or the tech, and not be communicated to a nurse or physician, or maybe the nurse and physician didn't talk to each other about what's going on, and things can be missed, and it's not what we want to do.
No, and I think that's all very good points. So I just want to say that is all the time we have for today. Again, I want to thank Dr. Neuberger for coming and taking part. To see the great work we are doing, please like our social media pages and subscribe to our YouTube channel. We invite you to visit our site at www.defeatingepilepsy.org to see how we are making a difference for the epilepsy community. Thank you for your support, and together we will defeat epilepsy. Take care.